My name's Helen Harrison. I'm the Associate Charge Nurse of Ward 6 at Kenepuru Hospital, which is part of CCDHB. Our ward mainly takes stroke patients or patients that have had a brain injury. They come to us from Wellington Hospital by referral. That's my phone, I'm really sorry. We knew there was a problem on Ward 6 because the feedback we were getting is that patients didn't know what their rehab journey looked like. The nursing staff, the allied health staff, we all seemed to be doing whatever we wanted, when we wanted, and very little of that involved the patient. So we knew that. So we needed to get started. We needed to engage all the professionals, and more importantly, we needed to engage a patient. We definitely knew that from the beginning. We formed focus groups. There were patient groups, there were allied health staff groups, with nursing staff involved, and crucially, we had senior leadership involved as well. We had to understand what was going wrong. We knew from our AROC data. Does anybody know what AROC data is? It's a way of measuring someone's function before and after they go to rehab. It's based on 350 hospitals across New Zealand and Australia, and the data is all collected. So what we did know was our patients were coming to us with lower FIM scores. That's not good. What we also knew was we were sending them home much better, and much better than most of the hospitals. But what we also knew from that was it was taking an awful long time for them to get to us, and that's not good. We needed to know from patients what was wrong. So the patients told us they didn't know when their therapy was going to be, they didn't know when their nurses were going to be there, they didn't know when they were going to have a shower, and why did I have a shower in the morning when I only shower in the afternoon. So there was numerous things that were going off in our world. The patient story that's up there, I'll talk through that very soon. We had to have shared learning and ideas, so we all got together, didn't we, Rose? Quite a lot of focus groups, and eventually we all agreed what needed to change. So we had a vision, we had a mission, we had actions, and we had clear themes. This board here, I don't know if you at the back can see it. So this board was what we used to have. On the left-hand side is the name of the patients on the ward, and then we had random magnetic labels to say when they were going to be seen by OT, where they were going to have lunch, when they were going to have the physiotherapy. But unfortunately, this did not often align with what was at the patient bedside. And this would get changed or not updated, and likewise the bedside one did. So we didn't know what we were doing, and the poor patients didn't know what we were doing. We thought this was brilliant when it first came out, because you could just walk up to it, have a look and go, oh, Mrs. Smith's having physio at 10, I won't go near her. But the reality was, it wasn't working. What we did well during all this, we had the focus. We removed the barriers, and we did this by getting together and all agreeing, because often different disciplines can work in silos very, very easily, so we had to break those down. We looked at the AROC data and the FIM data. We definitely had team engagement. Everybody knew there was a problem. The clear themes, we had people saying that they were sad, annoyed, they were scared, but also that they felt supported. What was challenging? So to begin with, like most of these things, they start off with everybody's got an opinion. So we had to focus that right down to what we wanted to achieve. We did a roadmap. We had the goals of the service. What do we actually want in rehab? We had clear responsibilities. Rose is currently responsible for the timetables. We had to change practice and views. Nurses can get very entrenched in what they believe is the correct way to nurse people. And they often feel a bit like telling the patients what they need to do. So we had to change, there was a bit of culture change there to make the nurses appreciate that this was actually the patient's journey, not theirs. We needed time and resources. Ours is a busy rehab ward and it's a busy hospital, even though it's 30 minutes up the road from Wellington, which is the acute hospital. And it's often difficult to get everybody together. So you have to try and make the effort. I'm going to read Amanda's story out. She was one of our key co-design partners. Amanda was with us for quite a long time. Hello, my name is Amanda, and I'm sorry I can't be here today. I'm at Wellington Hospital all day, so the team is kindly reading this out for me. I'm 22 years old. This story was presented to the board in...
I think it was earlier this year.
Yeah. But I spent the last 2.5 years recovering from a ruptured aneurysm in my brain. It's a hefty thing relearning how to eat, drink, breathe, see and walk, but it's been a huge learning experience. I'm glad that at last a lot of these experiences I've lived through can be rewarding and helpful in some way to improve the lives of other patients. I consider myself a bit of a professional at the patient experience, and she was, spending 5 months between Wellington and Kenepuru hospitals. A lot of people say this, but my family isn't like other families. My dad works 50 hours a week. My eldest sister flies all over the world as a free trade lawyer. My other big sister has special needs, and my mother doesn't work due to past health concerns, and she spends her time running our family. My family and myself had distinct goals and hopes regarding my hospital stay and recovery. Goals and hopes that were very much self-motivated, as I had already set some daily programme, chosen for me and out of my control. About a year post-discharge, I learned about the co-design work happening at Kenepuru, and I was so happy that this was being addressed so strongly. The most distinct and rewarding part of rehabilitation were those therapists that I or my family directly discussed with the rehab staff, like baking, going for a walk through the garden, and going to the hydrotherapy sessions. My family all have hectic schedules, but wanted to be able to spend as much time with me as possible, and they wanted to see me grasp back any aspect of my life and have some autonomy. This is what the bedside scheduling allows more than anything, for patients and the ones who know them best to make decisions about their own recoveries and express their own goals, what's most important to them and their families, and this being prioritised in our hospital stays. So Amanda was quite right. We very much dictated what her rehab journey was going to be. And it was so good to have her on board with this project because she showed us the patient side, the human side, what was important. It was really important that her family were there quite a lot for the rehab because they wanted to see it. And they were quite a powerful family, and we listened to them. But at that time, we weren't listening to the other patients on the ward, and we weren't taking into account their families because Amanda's was so strong. It's a bit like the squeaky wheel, but in actual fact, that's how it should be. So the highlights of this process is the team engagement with all parties. It kept it real and focused on the consumers, and it enhanced communications, enabling co-design methodology. I know there were a few more of the team invited here today to discuss their thoughts on it from different perspectives. But I just love the way now that we do this individual scheduling for patients. I'll pass around or walk around a timetable that we do. So Rose gets this ready on a Wednesday. And on Wednesday, Thursday and Friday, all the different therapies put their input onto the timetable. It was difficult. It's changed a couple of times now, this timetable. It was difficult at the beginning for nursing to put their bits on, because for those of you that are nurses, you know that your day can change within an instant. So we've modified the form a little bit. And maybe Rose, if I walk around, then maybe Rose can talk about a little bit about that, because she knows a bit more.
Hi everyone, I'm Rose, a physiotherapist on Ward 6, Kenepuru Rehabilitation Ward. So that's the timetable that we're using at the moment. It's still a limited method and means of taking feedback from all of those different consumers as well as our staff, because we don't have technology to support the process at this stage. But it's a way of working at the moment that means we are able to take on board what our patients find important for their rehab, taking into account their goals, and schedule accordingly. So we've changed it quite a few times, used different methods, and we've continued to gather feedback as we go, so we keep going forward with this kind of co-design project in that format by using our patients, getting their feedback as we go. There's things like we were using quite a lot of colours, and some patients found that really confusing. And then lots of things like Helen was talking about, our nursing staff. Patients and nursing staff found it confusing to have different nursing activities listed, so we've dialed that back and changed how we've done that as well. So we just kind of keep going with the process, I guess.
We print up big ones of these that go on the ward wall. We've got a designated wall for these, but crucially, the patients get their own copy as well. So, and if you're going to alter this, then you have to alter it on the main wall one and also on the patient's one. Whereas before we had the two different systems that didn't talk to each other. In an ideal world, for like what's next, we would move to technology. There are applications out there, but it involves a cost to the DHB, because each patient or each bed space would require a laptop or some sort of computer screen that we can feed into electronically, and then if it changes, it's an immediate thing and it talks to whoever's changed the timetable. We haven't gone for our half an hour, I'm sorry. Yes?
My question is about what were the learnings or the suggestions your group got from whānau in particular?
I think one of the most major learnings we found is that whānau patients, their ability to be either part of the session or actually just be able to visit the patient when they weren't scheduled for therapy, that was always really difficult prior to the scheduling. So now that the schedule is there the week before, whānau are able to get in, see when is a good time to work with the patient, but also talking. It's still not a dictated therapist or nursing staff timetable. There is that discussion now between patients, their whānau, and the staff, and kind of making it more of a process where we discuss when those scheduled sessions would be best for that patient in particular.